Okay. I may prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I rely on thee.
Thank you, ma'am. Thank you very much. Good morning. Welcome to all of you. I am Dr. Jayaraman. I am Academic Committee Chairman of IMA TNSB. So today we have a wonderful webinar. So may I welcome our State President, Dr. R. Palanisammy, sir. So thanks for this wonderful platform for this monthly webinar for our IMA members, and our State President-elect, Dr. P. Sendabil Pari, sir, and the Honorary State Secretary, Dr. N.R.T.R. Tyagarajan, sir, and our State Treasurer, Dr. V. N. Alagavengadesan, sir. So I welcome all our office bearers of Tamil Nadu State Branch. Today we are going to combine meeting with the Tamil Nadu Ophthalmic Association. May I welcome Dr. R.K. sir, Dr. R. Ramakrishnan sir, President of Tamil Nadu Ophthalmic Association, and President-elect Dr. Nirmal Frederick sir, and the Vice President of TNOA, Dr. Arulmozhi Varman sir, and the Secretary, Dr. Sriram sir, and the President, Dr. Balaji sir. I welcome all the delegates for this today's virtual CME to commemorate World Sight Day. Today the theme is Love Your Eyes. This is a wonderful topic, wonderful day. We are all going to enjoy. So these are all our academic committee member, Dr. Rekha from Chennai, Dr. Andagopal from Coimbatore, Dr. Bavaharan from Trichy, Dr. Anbu Selvan from Kanchipuram, Dr. James Kumar from Erode, Dr. Vinod from Tanjore. So this is the theme of this World Sight Day, Love Your Eyes. So small intimation to all the members. We are going to have the TMACON, Tamil Nadu IMA State Conference at Chennai Trade Center on 17th, 18th December. This is the 2 days program, Saturday, Sunday. Our state level program. This is like Diwali Pongal. This is a Muppuram Villa actually. One is a 2-day scientific feast and the installation of new president-elect, Dr. T. Chandamil Pari sir. And we have the Medi Expo in the exhibition hall. So I welcome all of you, all the members, kindly register in this TMACON in Chennai and enjoy the academic feast and all the programs we are planning such a way that meticulously we are planning. I request everyone kindly enroll this program. This is the registration form. You can do the online registration also. The last date for registration will be November 30th. I request everyone register. So with that, I thank you very much for this wonderful opportunity. I hand over the mic to Professor Dr. Nirmal Frederick sir, Chairman, for the further proceedings. Thank you, sir.
Thank you, Dr. Jayaram. So let me at the outset welcome all of you for this wonderful webinar. I thank the IMA leadership, Dr. Palanisammy, Dr. Sendamal Pari, Secretary Dr. N.R.T.R. Tyagarajan, Treasurer Dr. V. N. Alagavengadesan, and of course the ever dynamic Dr. Jayaram, Chairman Academic Committee. And our TNOA leaders, Dr. R.K. sir, Dr. Ramakrishnan sir, Dr. Arulmozhi Varman, Sriram, Dr. Balaji, and all others. So I also thank Dr. Jayaram for coordinating with us and making this possible, and of course the academic committee members. So thank you all for joining, and I welcome the delegates for joining us for this Sunday's program. So as you all know, World Sight Day is celebrated or commemorated on the second Thursday of every October on this premises with a theme, new theme every year. And this year because of the rousing welcome, they continue to have the theme for 2021, for 2022 also, Love Your Eyes, because not only catchy, it has also reached the majority of the population. And focuses on these 4 P's to prevent your eyes from many eye diseases by adopting healthy lifestyle and healthy diet, and preserve vision by regular eye examination, then prioritize care by Love Your Eyes. So this is of course the theme of this year's World Sight Day. And of course, protect and take care of your eyes from protective eyewear, clean your cosmetics, and work in a body-friendly way. So today's academic session, we have lined up one speaker for an important topic, pediatric eye care for the primary physicians. So this is relevant in today's scenario because of the huge pediatric population that is taken care by not only the pediatrician, but also the family physicians, general physicians, and the other specialists who come across this particular demographic age group. So this will be an important topic, and that will be given by Dr. S. Ramakrishnan. Followed by that, we have a panel discussion on eye and systemic disease. So very often we have so many dilemmas and questions during practice. So both ophthalmic as well as the medical aspects. So to clear those dilemmas and challenges and queries, so we have an interesting panel who will be introduced later. And so thank you again for joining us. Let me introduce Dr. Ramakrishnan. He's a pediatric ophthalmologist practicing at Vijay Eye Foundation Hospital, Chennai. Excellent expert pediatric ophthalmologist and a good orator as well. So welcome, Dr. Ramakrishnan. So I invite you. Over to you, Dr. Ramakrishnan.
Thank you for the.
And before that, before the talk, may I invite our TNOA President, Dr. Ramakrishnan sir, to give a special remark to us. So after that, we'll go to that.
Yes.
Okay, sir.
Yes. Thank you, Nirmal.
Thank you for joining us, sir.
I am
There's some overlap somewhere.
and Dr. Nandamul Pari and Secretary Tyagarajan and Academic Chairman Dr. Jayaraman and of course our own Tamil Nadu Ophthalmic Association President-elect Dr. Nirmal and Dr. Arunmozhi Varman, Sriram Gopal, Dr. Balaji, and the speakers of the day, Dr. Ramakrishnan, and the panelists, Dr. Kalpana, Satyan, and moderators. Everyone. Good morning to all of you. Really, it's a wonderful day today because IMA is a parent organization of medical fraternity. IMA is, we are organizing a webinar with IMA. It's a very, I have to thank Nirmal and Dr. Jayaraman for making it possible. As Nirmal told, today is a word because every Thursday of second Thursday of October celebrated as World Sight Day throughout the world. It's a global program, and of course, from the year 2000 onwards, it's celebrated. The main idea of this World Sight Day, especially the theme for this, the current year and the previous year, was the Love Your Eyes. That's a theme for the current year. But of course, the why this World Sight Day was observed throughout the world for the more than 22 years is just to make awareness about the magnitude of blindness, because at that time the blindness due to some of the non-communicable diseases like diabetes was so much increasing, especially in developing world like India and other countries. And also the visual impairment, the amount of visual impairment due to cataract, refractive error, ARMD, all these things are very much on the higher side. And third important thing is how to prevent this all these visually related problems, both in the government and also World Health Organization, how to improve the facility and how to improve the human resources. All these things are mainly important to have this to reduce the burden of visual impairment and blindness in India. And of course, in throughout the world, even our own country, various organizations like IMA and Tamil Nadu Ophthalmic Association, All India Ophthalmic Association, all bodies, they have observed, celebrated this World Sight Day in many ways by conducting webinars and some discussion, and also the marathon and essay competition and so many things for starting from school children, college children, and to the public. So in that way, we, Tamil Nadu Ophthalmic Association, we also conducted a webinar on 13th of this month, mainly to concentrate on the optic disc, that A to Z. What are all the changes you can get in by just looking at it, because you know, all of you, there's eye is the window of the human body. So by looking at the eye, you can diagnose so many systemic problems. So optic disc is one of the important which can be involved in both ocular as well as systemic diseases. So we organized a seminar. It was a wonderful meet on the other day. In that way, Dr. Nirmal and Dr. Jayaraman has organized a webinar. Especially, this will be very much useful for the general physicians, because most of the time we are not giving much importance for the ocular part, especially when even if you take about diabetes. You know, most of people will be diabetic for 20 or 30 years, but they will not be coming for the periodic ocular examination, especially fundus, because most of them are silent. Suppose if you diagnose early and treat them early, we can definitely prevent them going for blind. But once they come up with the advanced stage of proliferative diabetes, most of the people, they will come with a sudden loss of vision, and 20 years of diabetes, no ophthalmic sarcoma, something like that. So this seminar definitely will instigate the general physician to have their patients periodical eye checkup, so that they can diagnose this type of blinding diseases. Not only that, we can alert the patient. We can alert the patient to have a simultaneous checkup to rule out any nephropathy or any cardiac related and peripheral neuropathy, etc., so that they can have a wonderful quality of life with accurate treatment. So in that way, there are two topics, as Nirmal pointed out, is a wonderful topic, especially the second one and the first one. Definitely it will be useful, because so many systemic diseases will be associated with the ocular manifestation. So it's better to know, and definitely the panel, they have a wonderful experience in both systemic as well as ocular diseases. Definitely it will be useful. And also I request November 14th is the World Diabetes Day. So I request all of you to do something to make awareness about the diabetes and diabetic related complications like diabetic retinopathy, nephropathy, and all other things. This I just once again welcome all the panel moderator and office members of TNOA and IMA. Thank you very much. Thank you.
Thank you, sir, for your words of wisdom, and also highlighting the importance of screening and working with the other specialists and medical people in highlighting the important aspect of preventive eye care. And of course, World Diabetes Day is due in November. Hopefully, we'll do some program together to highlight the challenges associated with diabetic retinopathy and also the preventive aspect of diabetic care. So thank you so much for your kind words. Do we have Dr. Thangavelu sir, past president of TNOA? So can you share a few words, Dr. Thangavelu sir? Then we move on to the academic part.
Mute.
Yes, sir.
Morning, everybody. It's nice to be associated with IMA and TNOA. It's often a pleasure to be a part of this IMA TNOA meetings. Very well said by the president, our TNOA president, Dr. Ramakrishnan. He has very well said what is the importance of associating with Indian Medical Association and the doctors. We normally see patients who are with advanced stages of diabetic retinopathy or glaucoma, which we could have detected a little early and prevented blindness. So this is the only take-home message which Ramakrishnan has elaborated very well. What is the importance of this webinar? Thank all the organizers, Dr. Jayaraman, Dr. Nirmal, all the panelists, my colleagues, for giving me an opportunity to say a few words. I hope this will be an eye-opener for all our colleagues to take care of our patients' vision also. Thank you very much, Dr. Nirmal, for asking me to say a few words.
Thank you, sir. Okay, so our IMA president may be joining us a bit late. So we'll move on with the academic program. Over to you, Dr. Ramakrishnan. Yes, Ramakrishnan.
Thank you, sir. Is my screen visible, sir, now?
Yes, make it slideshow.
Okay.
Yes.
Good morning, everyone. I would like to thank the IMA and the TNOA for providing me with this opportunity. A blind child is always a burden on the society. A child that is going blind today will live with us for the next 60 to 70 years. One can imagine if this blindness is preventable, one can imagine the amount of man years that can be saved. Why should we concentrate on children? Children are more vulnerable to permanent damages because of the growing visual cortex and the visual pathways. Any condition that is not treated at the appropriate time, because of this growing nature of the visual system, it can lead to profound visual loss, which can be irreversible. Some of the challenges that we face when we deal with children, it is very difficult to accurately determine a child's corrected visual acuity because of the age and because of the cooperation levels we get. The visual demands of a child varies depending upon the age. A little child, the visual demands are very limited. Their activities are mostly the activities are mostly confined within a room. And as the child grows, the activities changes and the visual demands also change. And as I mentioned earlier, because of the plastic visual cortex and the visual system, which is ever growing, it places them at an increased risk of amblyopia and strabismus. Various surveys have estimated around 200 to 300,000 children in India have severe visual impairment, and more than 15 to 20,000 children are in schools of blind. Where we can play a role is approximately 50% of all childhood blindness in India are either preventable or treatable. Some of the commonest causes of childhood blindness include genetic disorders, maternal infection, congenital cataract, and uncorrected refractive errors, which form almost around 45 to 50% of this childhood blindness. Most common pediatric eye problems can be broadly classified under these subsects: congenital, traumatic, inflammatory, refractive errors, and squint. And we will see some of them in brief. The growth of the human eye is greatest during the first 2 years of life. Thereafter, it slows down gradually. Any condition that affects the physiology during the first 2 to 3 years of life can have a permanent impact on the visual development. Few important visual milestones that needs to be kept in mind. The blink reflex is present at birth. You shine a torchlight and the child blinks, which means that the visual system is active. And the normal fixation and social smile develop around 4 to 5 months of age. Amblyopia is basically unilateral or bilateral decrease in the visual acuity in spite of a normal anatomy, and which with no organic cause can be found. And in appropriate cases, if it can be reversible, if therapeutic measures are taken at the right time. Pediatric cataract contributes to almost around 5 to 20% of childhood blindness worldwide, and it is one of the major causes of childhood blindness in developing countries due to late presentation and treatment. Pediatric cataract causes blurring of retinal image. This disrupts the development of the immature visual pathway and the visual cortex, and which can lead to dense amblyopia. If this is not treated at the right time, the dense amblyopia may become irreversible. Heredity is the most common cause in developed countries, whereas in developing nations, the leading cause of congenital cataract is maternal infections. Dense cataracts present with obvious white reflex or leukocoria, delayed social smile, and nystagmus can be presenting symptoms of congenital cataract. Older children present with defective vision if they are the school going age. A thorough systemic evaluation is mandatory to rule out any associated systemic abnormalities due to infection or metabolic disorders. This also helps in planning for the risks associated with general anesthesia when planning for surgery. The visual prognosis depends on the age at which the cataract is identified. The visual prognosis is very good if it is identified early and treatment is initiated early. Bilateral cataracts have better visual prognosis than unilateral cataracts due to amblyopia. Presence of squint and nystagmus imply dense underlying amblyopia and hence poor visual prognosis. Surgery is the mainstay of treatment for congenital cataract. The IOL implantation is as a primary procedure is the mainstay. It depends on the age and whether the cataract is unilateral or bilateral. Nevertheless, IOL implantation gives the best possible visual rehabilitation. Next, we'll move on to refractive errors. Refractive errors are one of the top causes of preventable childhood blindness in our country. Almost 3 to 5% of school-going children have some form of refractive error. And one of the studies which I saw in the everybody would have read in the newspaper today, the LVP study, recent study, have shown almost 20% of school-going children having refractive errors in the after the recent pandemic. A simple glass, the positive news is a simple glass prescription can improve the quality of vision in almost 95% of these children. Untreated refractive error can lead to strabismus and amblyopia, and if it is not treated at the right time, it may lead to permanent visual loss. And the plasticity of the visual cortex at the younger age places them at a higher risk of permanent damage. And we have nowadays we have a lot of evidence-based guidelines to treat refractive errors in children. The natural progress of refractive status starts from moderate hypermetropia in a newborn and reaches emmetropia by around 6 years of age. The growth of the eyeball is rapid during the first 2 to 3 years, and thereafter it gradually slows down. This process, where it starts with hypermetropia and reaches emmetropia or zero refractive error, is called emmetropization. When this process of emmetropization fails, it leads to refractive error, and if it is not treated at the right time, the risk of amblyopia and strabismus is increased. Hence, it is very important to monitor the refractive status in children, preferably at 6 monthly follow-up. Early identification can prevent severe visual loss. And as I had mentioned earlier, a simple glass prescription can drastically reduce the risk of permanent damage due to strabismus and amblyopia. Special children need special consideration. Generally, the emmetropization process, which I mentioned earlier, fails in special children like Down syndrome and any other developmental delays. Hence, even smaller refractive errors need to be corrected in order to improve their visual acuity, and which also helps in the overall development. Why should we give glasses? There are multiple indications for spectacle prescription. The main and foremost reason is provide better vision, and the spectacles provide better quality of vision. They reduce amblyopia and they help in treating certain types of strabismus. And in older children, it helps to relieve asthenopic symptoms. And in certain cases, it also acts as a protective gear. Can we do refractive surgery in children? Refractive surgery in children is generally not advisable. It is because of the growing nature of the eyeball. Refractive surgery is generally reserved for extreme conditions where therapeutic benefits outweighs the associated risk. Some of the indications include high refractive errors and in special children where glass prescription might not be feasible. What is low vision? A best corrective visual acuity of 6/18 or less, or visual field with 10 degrees, less than 10 degrees is considered as low vision, and total absence of light perception is considered as blindness as per WHO definition. What is functional vision? Children with low vision, functional vision is the way in which the child is trained to use whatever low vision the child has. We need to assess the child's visual acuity, visual fields, and also other parameters like contrast sensitivity, light sensitivity, and intelligence also. And based on these parameters, we can train the children to use their visual, whatever vision is available to the best possible potential. There are three types of training which can be given. One is vision stimulation by improving the visual efficiency and with the help of low vision devices whenever possible. Vision stimulation can be done with colorful lights, some toys with bright lights, and even boards with LED lights, colorful LED lights with sequential glow. And visual efficiency can be improved by training them in hand-eye exercises, which improves the hand-eye coordination, like these beads matching, sequencing, tracing, etc. We'll move on to squints. Basically, roughly around 4 to 5% of children have squint at one time or the other. Basically, it is a misalignment of the eyes where one eye looks straight and the other eye is pointing in a different direction. Both eyes are not pointing towards the same direction. This is the case of congenital esotropia or convergent squint, where one eye is pointing straight and the other eye is deviated inwards. And this is the case of congenital exotropia or divergent squint, where one eye is pointing straight and the other eye is deviated outwards. This is an example of accommodative esotropia, which happens due to high hypermetropia. There is a convergent squint, and a simple glass prescription can cure this squint. It happens due to high hypermetropia and the associated increased accommodation and convergence if it is not treated. Pseudostrabismus is one common presentation in the pediatric clinic. The most common cause is due to wide nasal bridge or epicanthal folds. It gives an appearance as a false convergent squint. Just a simple reassurance is needed, and as the child grows, the condition improves. The appearance improves. Basically, there is no squint. So what are the symptoms of squint? How do children present? Large angle squints obviously present with squint. Children may also brought to clinic with complaints of defective vision, abnormal head posture, and sometimes maybe totally asymptomatic also. Some of the indications for surgery. Basically, surgery is done obviously for cosmetic reason. Surgery is wherever there is a possibility. In the younger age, there is a possibility in improving the functional quality of the vision, like improving binocular vision, stereopsis. Surgery is indicated, and surgery for cosmetic purpose can be done at any age, even adults. And some cases, surgery may be indicated to eliminate diplopia where there is a paralytic squint. Now we shall see some other common eye problems that children can present with. The congenital nasolacrimal duct is one of the commonest cause for watering in eyes in children. It is due to the failure of the opening of the nasolacrimal duct on the nasal side. Almost 50% of the cases resolve spontaneously. Typically, children are brought around 1 month of age with epiphora. Usually, it is unilateral, may be associated with discharge. And pressing on the side of the nose or the sac area can cause regurgitation of fluid through the canaliculus. Rarely, the nasolacrimal duct obstruction can present with dacryocele or even acute dacryocystitis, or sometimes even cellulitis. (60 to 70% of the cases resolve spontaneously, and the first line of treatment is the lacrimal sac massage, which is effective up to 1 year of age. Almost 60 to 70% of the children resolve with simple lacrimal sac massage. If it is more than the child is more than 1 year of age, probing and syringing is advised and under GA, and older children more than 3 to 4 years of age may require dacryocysto-rhinostomy surgery. Birth trauma usually happens in case of assisted delivery or forceps delivery. Children usually are brought at the school-going age with defective vision. Examination reveals damage to the Descemet's membrane, which is the deeper layer of the cornea, with a scar, linear scar, and it can lead to severe astigmatism and dense amblyopia depending upon the age of the presentation. Megalocornea is abnormally increase in the size of the cornea. It may be unilateral or bilateral. It is megalocornea in an infant is one of the earliest signs of congenital glaucoma, and any infant with megalocornea should undergo a thorough examination, preferably under general anesthesia, to check for congenital glaucoma. Albinism, ocular albinism may present with or without association with cutaneous albinism. The fundus is typically very tessellated due to lack of pigments. Vision may be poor due to foveal hypoplasia and associated nystagmus. Capillary hemangioma are usually self-resolving. Treatment is not required unless it causes, the hemangioma is large and it causes mechanical ptosis. Mechanical ptosis can obstruct the visual axis and cause dense amblyopia if it is not treated. If it is not obstructing the visual axis, if it is not causing ptosis, hemangiomas can be absorbed. Topical application of timolol solution is helpful, and in large cases, intralesional steroids may be tried. Bitoid spots are not very common nowadays. It is caused by vitamin A deficiency. It presents typically as a frothy, dry patch over the conjunctiva. Retinoblastoma is the commonest primary ocular tumor in children, originates from the retinal progenitor cells. Most common presentation is leukocoria or white reflex, almost 60% present with white reflex, and almost 20% present with strabismus. This is one of the main reasons why all children with strabismus should undergo a dilated and detailed fundus examination. Rarely it may present with uveitis or glaucoma. Treatment modalities depend upon the age of the child and the severity and stage of the disease for retinoblastoma. Retinopathy of prematurity, it is almost 20% of world's childhood blindness is in India, and 1/3 of preterm infants develop ROP, out of which almost 3 to 7% become ultimately blind if it is not treated at the right time. The incidence of ROP is recently increasing because of better survival of low birth weight and preterm babies and better modern neonatal facilities and care. The risk factors less than prematurity and low birth weight, the guidelines are less than 34 weeks and less than 2 kgs are at risk, needs screening, and less than 28 weeks and less than 1000 grams are at highest risk. The factors like prolonged oxygen requirement, multiple blood transfusion, associated sepsis and shock increases the ROP risks. The disease can be staged depending upon the growth of the vessels, new vessels. Stage 1, stage 2. Stage 1 is mild. As the stage increases, the severity is more. And treatment, basically, it is laser, cryotherapy, and intravitreal anti-VEGF injections nowadays, and surgical management in advanced stages. To conclude, timely screening and referral and treatment to prevent blindness, ROP screening programs as a combination with neonatologists and ophthalmologists, and better referral services and advanced vitreoretinal expertise in advanced stages. Thank you.
Thank you, Dr. Ramakrishnan, for the wonderful talk on pediatric eye care and important points related to the common eye problems in pediatric age group. Of course, the last part, the ROP, retinopathy of prematurity screening, and also the referral guidelines needs to be re-emphasized in view of the medical legal implications.
I would like to thank Dr. Sriram Gopal for providing me with the ROP inputs. May I request Dr. Sriram to...
Yeah, I'm about to call him.
Yeah.
So what are the actual referral guidelines? What should a physician do? What should the pediatrician do? What should the NICU unit do? And I also request input from Dr. Sriram.
Cannot hear.
Yeah, I was muted. Thank you, sir. Thank you, Dr. Nirmal. Yes, ROP is a very, very important thing, as Dr. Nirmal mentioned. It is acquiring gigantic proportions, because on one side we have a lot of NICUs and neonatal care spreading across the country. Like every small town, even you live alone cities, small towns are getting neonatal care. All government medical college hospitals are now having neonatal care, but the screening for ROP, leave alone the treatment, the screening for ROP has not penetrated that much. So that is where the problem lies. So we, instead of looking at specialists like retinal surgeons or pediatric ophthalmologists screening for ROP, I think we should start looking at ophthalmologists themselves screening for ROP. I don't think screening for ROP needs any special expertise. So if every small town ophthalmologist can take care of the NICUs in this area, I think that is how we can solve this problem. We can invest in all fancy retinal cameras and send vans to abroad, but we have so many ophthalmologists, especially Tamil Nadu, which I'm sure our past president, and my president-elect also will agree that we have a plethora of ophthalmologists here. I think the primary ophthalmologist should be adept in at least screening for ROP, because if you screen 100 children for ROP, only 5 of them actually need a referral to an expert like a retinal surgeon or a pediatric ophthalmologist, of which only 2 or 3 need treatment. But if you fail to screen the 100, you fail to pick up that 5, you end up with 3 blind children for the rest of their lives. So that is where this thing occurs. And all 3 are potential high-risk medico-legal cases where the compensation runs into at least 1 crore, going by the past history. So screening guidelines is one thing. Any child with what Dr. RK said, less than 36 weeks, less than 2 kilos needs to be screened. But who can screen? I think we need to expand our scope and ensure that every ophthalmologist is adept at screening an ROP child. That is my take on this subject.
Yeah, thank you, Sriram. The screening guidelines are already there, and only because of the medical legal ramification and the huge amount as compensation, it is preventing ophthalmologists from seeing. And also, as you rightly said, that has to be institutionalized. You don't need a retina surgeon to screen ROP. Okay, so the take-home message from this webinar should be very strong, that all ophthalmologists should be doing ROP screening, and don't bother about the medical legal implication, because it is also part of standard of care. You come across a retinopathy ROP preterm baby and the parents come to you, it is your duty to screen the retina. Same way, the pediatrician, we also need to send a message to all the pediatricians. It's not only the preterm babies, but also any child who has underweight, has all these risk factors, have to be referred to an ophthalmologist for proper retinal screening. So any other inputs?
Nirmal.
Yes.
Yeah, as a general ophthalmologist, if we screen for preterm, will it hold good for in the court of law?
Yes.
Or those kids should be seen by the trained retina specialist?
No, all of us are trained in fundus examination and retina.
Yeah, that is there, but in the court of law, will it hold?
No. Legally, what they look for is standard of care. In fact, the standard of care says the ophthalmologist have to look at the fundus, a dilated retinal examination, if there is a high risk. So you have to do a risk assessment for the baby and then screen for fundus, and of course give the report. You need not be scared about missing some findings or something. If you have a suspicion, you can always refer to the retina surgeon.
Yeah.
Just to reiterate the point, I think it's no different from screening for diabetic retinopathy. It is like even in diabetic retinopathy, you wait until a vision-threatening stage and then send it to a retinal surgeon. In ROP, it's much more simpler. Even if you have a stage 1, you refer. It's as simple as that. If there is no ROP, don't refer. Fully vascularized retina, no, don't refer. This way, more than 90% of the children won't need to go for a specialized care. Only 10% of children will actually need to be even seen by a retinal surgeon, leave alone treatment. In that, a smaller proportion is needed to treat. So it is just a mental thought block, very small child. You need to use an indirect and you need to indent the eye using a vector. It's more of a thought block, madam. I think in our future TNOA wet labs also, I think we should do something wherein we can promote to this aspect of eye care, sir, ROP screening.
Definitely.
Yeah.
And one more thing is, I
Yes.
wanted to ask Dr. one question for Dr. Ramakrishnan. I had, okay, like immunization, is there any standard protocol wherein you would say a child needs, an absolutely normal child needs to have an eye checkup at this and this age? Irrespective of symptoms, absolutely normal, healthy child, you would still ask the pediatrician to send it to an ophthalmologist, not necessarily a pediatric ophthalmologist.
See, in Western countries, there is a mandatory rule in US or something, mandatory rule that before you join school, you need to produce an eye checkup certificate. So that simple examination, just a vision checkup at that age, just before joining school, will help us identify many refractive errors and help us treat many amblyophias. I think one suggestion is even all pediatricians, even general physicians, we can have one vision chart in the clinic. At least if whichever patient they come to the clinic, they can ask them to read the vision chart and easily identify any just one form of screening, which I thought. But otherwise, one eye checkup before joining school at school going age around 3 years will help us identify many uncorrected refractive errors and prevent amblyopia.
Yeah, thank you.
Some schools which
thank you,
actually are
Ramakrishnan.
implementing it now.
Yes, some schools have started implementing this. So we have also written to the Collegiate of Education and the ISA board to see that they can make this important aspect of how to comply with this requirement. A preschool screening at the age of 3 before they join the school. So we also written to the Human Rights Commission to make it mandatory, because we are missing so many myopia, astigmatism, lazy amblyopia, and of course some of the ROP patients, and many patients with eye disease which are treatable are being presented in the school.
Yes, sir, that will be wonderful.
One mandatory eye screening before the child joins the school, and one maybe at 1 year and 3 years. So this is the schedule generally recommended in Western countries. At birth, 6 months, 1 year, 3 years, that is before the school, and after that, regularly if they have eye problem, every 2 years.
Some things I think we should include it in the immunization schedules. Only then that will be adhered to.
Yes, yeah. I think we can work with the associations, particularly the IAP, Indian Academy of Pediatrics. We can write to them and see how we can approach their members. So see to that is part of the regular recommendation. So thank you. We'll if there's no other inputs, we'll move on to the second part. Can we?
Yes, sir.
I think there is one question from chat box.
Okay.
You can take it up. Take it up.
What are the problems in children using cell phone and iPads? Nowadays, even children are all addicted. Patients really don't know how to prevent them from watching. RK?
Yeah, one of the main drawbacks of this digital screens and more indoor activities we have seen in the last 2 years because of this COVID associated increase in the use of online gadgets is the increase in the refractive error, increase in the progression of pre-existing refractive error. We see a lot of new children with myopia, and pre-existing myopia, the refractive error has increased. This is one of the main drawbacks, and obviously we need to reduce the amount of time spent on digital screens and improve the outdoor activities. And if you see, almost 20% of children, school-going children, have refractive error in India. If you see the numbers, similar numbers in Singapore, it is almost more than 80%. So they have implemented compulsory outdoor activities for children nowadays. So definitely we need to reduce and increase the outdoor activities.
Yeah, so in fact, I recently went to Malaysia. I heard a few schools are having compulsory 2-hour sunlight session and classes in the shades or outdoor classes. I think we have to go back to our Marathadi classes now.
Yes, sir. Gurukulam.
Yeah,
Singapore,
yes.
almost 80% children are wearing glasses. So they started this compulsory outdoor activities.
Okay, thank you, Ramakrishnan, for the wonderful talk, and also
Thank you,
all
sir.
the faculty members for the discussion. So we move on to the second part of the program, panel discussion on the eye and systemic disease. So I invite the moderators, Dr. Sriram Gopal and Dr. N. Satyan, to help me with this panel discussion. Dr. Sriram Gopal is a vitreoretinal surgeon from Atreya Retina Center, Trichy. He also the honorary secretary for Tamil Nadu Ophthalmic Association. Dr. N. Satyan is a glaucoma specialist, past president of IMA Coimbatore. So thank you, Satyan, and also the managing committee member of TNOA. Thank you, Satyan, for joining us. So have pleasure in introducing the panelists. Dr. V.S. Hariharan is a physician, consultant at Global Hospital Chennai and H2 Clinic Chennai. Thank you, Hari, for joining us. He's also a very busy physician and AMF chairman of IMA Tambram. Welcome, Dr. Kalpana Suresh, the medical director, senior ophthalmic surgeon, Kalpana Eye Care Chennai, former professor and HOD of Sri Ramachandra Medical College, and a good friend of mine and a famous YouTuber with a wonderful educative eye care videos. Welcome, Dr. Kalpana. Also, happy to welcome Dr. Jayashree Arunaprakash, ophthalmologist and medical director, Dr. Agarwal Sai Hospital, Coimbatore. Thank you, Dr. Jayashree, for joining us. And Dr. Vivek Sundaram, physician, Sundaram Hospitals, Trichy. Thank you, Dr. Vivek. And welcome Dr. N. Subramanian, the rheumatologist and assistant professor, Velamal Medical College, Hospital and Research Institute, Chennai. Currently also the vice president of Tirunelveli IMA, with a lot of awards and presentations and also responsibilities. Thank you, Dr. Subramaniam, for joining us.
Thank you,
We
sir.
have a
Good morning.
wonderful panel and look forward to a very informative discussions and interactive discussions. Over to you, Sriram.
Thank you, Dr. Nimal. Thank you so much. Dr. Nimal, could you allow me to share my screen?
Yes, yes.
I can just bring up the questions. Makes it easier that way. So we have five eminent panelists here. We have a physician, we have a diabetologist, we have a rheumatologist, we have an ophthalmologist, and we also have an ophthalmologist come retinal surgeon. So we basically divided the question into 4 parts. There will be some overlap. So we will try to take these questions one by one. One second. Okay. So I think we'll start off with this first question, which probably at least four of them will have something to say about it. So the main common interacting point between a physician and an ophthalmologist is usually regarding diabetes control or any fitness for eye surgery in general, and especially with specific reference to diabetes control for eye surgery. There are a lot of data and references on what is diabetes control and what you can take up for elective surgery, but there isn't something which you can actually produce in the court of law and make your point. So what is the ideal control for diabetic surgery? I ask this because we are faced with different kind of situations. We have somebody with a very low HbA1c of say 6.5 or 7, but on that day his sugar is high. A patient has had a fasting and PP 48 hours before, which is well within normal range. When he enters the hospital, I do a random, it is high. Whereas we have the AOS guideline, which actually it is meant more for mass cataract surgery in camps, but that tells us the random on the day of surgery should be less than 200. So that would mean that with a HbA1c of 12 and a random of 150 on that day, he is fit for surgery. So what scientifically is the right diabetes control for an elective eye surgery, especially cataract surgery, and what will stand in a court of law? This is my question. I think we'll first address this question to Dr. Hariharan. Sir.
Good morning, sir. Thank you for the opportunity. Yeah, the commonest point where ophthalmologist and physician interact is fitness for a cataract surgery. I mean, for any surgery, the two things that you should consider is patient's safety and the comfort level of the operating surgeon. So, and the third thing is if there's an emergency for the surgery. So, I think American Association of Anesthesia has said pre-op test for cataract surgery is not absolutely necessary, and things can be done. So, if at all, but this is the only point in time where we interact with the patients, and most patients will comply if you say, okay, get your sugars down, then you will have the surgery and it can be done. So, I used it as an opportunity to control their sugars and then take it forward. But I think the most important thing is the guideline that says, on the day of surgery, if the sugars are less than 200, it's documented. I think you can go ahead with the surgery. This is science. Because the cataract surgery is a very small surgery, and the risk of infection because of that is on the lower side. But the catch point is if the HbA1c is greater than 10, I think if there's a retinopathy, it progresses very fast. So I think I will do personally, I will do a regular sugar test, get the sugars under control. If there is time for the cataract surgery, I usually take a little time, get the sugars down, and then give a fitness for the surgery. This is my personal take on that.
So, just as a rider to that question, we'll move on to the next one. How would you prefer to reduce blood sugar within a short period of time? So we think the cataract surgery is an elective surgery and we can take time to do it. But a lot of times our patients, even though they have defective vision for 1 year, for a lot of social and other reasons, they want surgery within 1 week.
Yeah. That's the most important thing. So people go on with cataract for years and they'll come tomorrow, நாளைக்கு surgery பண்ணனும், இன்னைக்கு சுகர் இப்படி இருக்கும், நாளைக்கு நான் என் பையன் வந்து US போறான், அதுக்கு முன்னாடி சர்ஜரியை முடிச்சுட்டு போனோம் அப்படின்னு. That's the commonest thing that we face. I think we should take a little time and sit and educate them. Okay, cataract has been with you, and it may not be life. So mature you get people even with very mature cataract. That's a different story. But people with cataract just having time to go through a sugar control, I think I will use it as an opportunity to get the sugars down gradually. Maybe take a week, 2 weeks. Get them into the system and then give a fitness. This is my take on that. But I think, we see lots of camps happening, right? Where you pick up 30 people together, do a random sugar on that day, get the surgery done, go back home, and most of them don't come back with any problem. So I think, although the science says that can be done, I will still stick to, for my patients, I will stick to getting a good control before going for an elective surgery.
I'll just go on to Dr. Vivek for input on this. Vivek, your take?
Yeah, two things. We don't have any specific guidance to say these are the correct glucose values pertaining to eye surgery. We just extrapolate what is advocated for any surgery in ophthalmic surgery. And the perioperative value is 80 to 180 because anything more than 200 increases your risk of infection, though the risk of infection is very minimal pertaining to cataract surgery. In that case, you do a fasting and you do a postprandial. The postprandial is less than 280, he's fine for surgery. Why do you actually do a fasting in that case? Because you do a fasting because you don't want the patient to get hypoglycemic on the day of surgery when he's actually planning. So that would actually deter you from proceeding with the surgery in the first place. And you were talking about A1C. Doing the A1C preoperatively is not warranted for any surgery as such. Any A1C more than 15 is a contraindication for any form of surgery. And A1C does not influence your risk of infection post-surgery. In that case, forget about A1C. Now let us take these subsets. Patient has cataract, he's a diabetic, and he has underlying proliferative retinopathy or probably macular edema. Let's say his A1C is very much on the higher side. In that scenario, I would not be looking at rapidly decreasing A1C, because that is one setting where you'd actually worsen his macular edema. So in that case, I would gradually decrease his blood glucose. I would not decrease A1C by more than 3% in 3 months. Why? Because if you rapidly decrease blood glucose and proceed with cataract surgery, you have the small risk of actually transiently worsening his macular edema, thereby his visual acuity at the end of 1 year might be hampered. And we prefer to reduce blood glucose in a short time before any eye surgery. If it's cataract, there is no emergency. You just wait, take your own time. But any other ophthalmic surgery, if you think that the surgery has to be done immediately, I would prefer to start them on insulin straight away. We usually hospitalize them and shift them to the ophthalmologist straight away from the hospital if you think the delaying surgery is indispensable. Any other ophthalmic surgery. Regarding cataract, I think we can wait.
Yeah, thank you.
Sir,
Thank
if,
you.
sir, if it is the case of a mature cataract needs immediate, intermittent cataract needs immediate surgery in a day or two,
yeah,
probably we cannot, we have to take a risk of operating early despite having a fluctuating sugar. So what is your take on that?
Yeah, 2 days is enough of a time for us to optimize blood glucose before doing surgery. We can do
perfect, sir.
Perfect. Insulin, make him sugar fine, and we can shift him straight away for surgery. So
yeah, in case of emergency, we can even have a 2-day window period, and then you can take up for surgery.
Exactly. You don't have to.
Okay, sir. Okay, sir. Sriram, sir.
Thank you. Thank you, Vivek. One small disagreement with you, in fact. Sorry. This worsening of retinopathy, it says we go back to 80s and 90s with the UK PDS and the DCCT and the ETDRS study trials. That is where they suggested that intense glycemic control actually worsens retinopathy. So the way to look at it is, when you're doing an intense glycemic control, this person can worsen, so you monitor them more. But with experience and a lot of other data as well, I would say if somebody has got proliferative diabetic retinopathy already and macular edema, I don't see any reason to take it slowly. In fact, it was the more quickly and the more intensely you control diabetes, the need for further repeated treatment, because now we're in the era of anti-VEGF, we keep giving injections every month. The need for repeated treatment actually comes down. Yes, if somebody has got just sub-threshold or non-vision threatening retinopathy, in that patient, if you have intense glycemic control, he can cross the threshold and go into vision threatening and develop macular edema or even proliferative retinopathy. But somebody who already has proliferative retinopathy and already has macular edema, I don't see a reason to delay or take it slowly. In fact, make it more intense, but at the same time, keep the eye follow-up and eye treatment also very frequent and very intense. That is when we can reach our target more quickly and in a better way without much of visual loss.
Yeah,
I agree with Dr. Sriram. Because one thing is the patient's point of view. When we sensitize the patient that all your problems are because of the diabetes and it has to be controlled immediately, he seems to take it a little more seriously than when you say that no, this blood sugar has to be gradually controlled over a period of 3 months or 4 months. Then the seriousness from the side of the patient also reduces. So one is that we would like to sensitize the patient and tell him that all your diabetic retinopathy problems are because of diabetes and it has to be controlled at the earliest. And second point, even if there is a worsening, the only thing we would like is to have a close follow-up of the patient. So whatever diabetic retinopathy can be treated, it's not that it is cannot be treated. As Dr. Sriram said, all these guidelines were given long back when anti-VEGF was not there. Laser was the only mode of treatment. But now, because of the advancements, it can definitely, diabetic retinopathy can be managed very well. So I mean, as an ophthalmologist, we don't see that worsening of diabetic retinopathy to be a hindrance in controlling diabetes.
Yeah, I agree. That is absolutely true.
And second thing I would like to ask is, in case it is a retinal surgery or it is an emergency surgery like a mature or a hypermature cataract, within 2 days we put the patient on insulin and do the surgery. For how long would you want to continue the insulin? Would it be for a month, or would it be like a part of the normal treatment schedule, and as long as the diabetes comes into control, and then you can safely shift him from insulin to oral hypoglycemics? What would be the strategy for such patients?
Short-term preparing the patient, we start them off insulin, because the earliest way by which you can optimize glucose control, your aim is to reach a target of less than 180 to decrease the risk of infection. Post-surgery, your target basically depends on his baseline A1C. You can always switch him over to OHAs because continuing insulin over a long time depends on his total glycemic load, his A1C. And regarding the intensive therapy, yeah, I go ahead. Intensive therapy is the need of the hour. Now, we do not know, but when they say rapid reduction of blood glucose, we do not know how do they define this rapid value. Now, we have only data from Japan that says decreasing A1C by more than 3% in 3 months. This is pertaining to retinopathy deterioration is only transient with intensive glycemic control. It's not long term, the benefits would still be sustained. So we just have a rough guideline that says don't go beyond 3% within 3 months. Intensive glycemic control is the need. We're looking at long-term benefits. But short term, I don't have a definitive answer, but this was only from one data from Japan. Pertaining
Thank
to
you. Thank you. Thank you.
And another question
Sriram,
regarding
Sriram.
the diabetic control for eye surgery. Like we say, on the day of surgery, we need a blood sugar of less than 200. But Dr. Sriram said, and we have rightly seen that many patients, we have a 48-hour report or a 24-hour report where the fasting and PP is normal. But on the day of the surgery, it has skyrocketed either because the patient is traveling or if the patient is on a high dose of insulin. Sometimes we would like to withhold the insulin or give a lower dose because the surgery being prolonged surgery, and generally we do not give IV fluids during retinal surgery. So a 1 hour or a 2 hour surgery, the patient waiting for some time before surgery may go into hypoglycemia. So, and because patient being anxious, patient does not take adequate food also on the day of surgery. So we have seen patients going into hypoglycemia. Sometimes we feel that it is better to skip the dose of a morning dose of insulin on the day of surgery. So in those cases, definitely our random would be more than 200.
Yeah, and to add, just on that note, I would like to add that the American Academy of Anesthesiologists' recommendation for anti-diabetic medicines on day of surgery is to skip oral
skip the oral hypoglycemic.
So that is where this random of less than 200 on the day of surgery leaves me perplexed. If you're going to skip OHA and give half dose of insulin on day of surgery, then why would you want a random less than 200? So this is loggerheads.
To add to that dilemma, this giving a particular number 200 doesn't hold good for these patients because many of them have CKD or some other comorbid disease. So it gives a variable picture. I think we have to
add another dimension to it, sir.
From the guidelines.
And Nirmal sir, I want you to add another dimension to it. So when such a case, let us say a patient has a cataract surgery, has an endophthalmitis a week later, but had a random of 230 on the day of surgery. When it goes to court of law, what happens?
Okay, so two things. One is
the Pandora's box, I know, but still.
Okay, no. So this particular number, generally, when we frame guidelines, we don't give a particular guideline number. We give a range, and this range should be based on physician assessment and risk assessment of the patient. So anywhere in ophthalmic surgery or any surgery, apart from the initial assessment, we are supposed to do a reassessment on the day of surgery when you admit for procedure or when you take up for procedure. So during the reassessment, if we feel that the risk profile is high or patient has a high risk of infective chance, it is up to you to decide on the risk, high risk pattern. So if you feel that patient has a hypermature cataract, how to be operated. So in spite of blood sugar being 250 or 280, you can go ahead. So as a surgeon, you have this privilege of deciding for the patient, right? So this has to be documented. It's not just keeping on with the numbers. This has to be documented in the case record that why you took the case in spite of the higher blood sugar, and you have to justify the risk.
Yes,
but in
sir,
case of an adverse outcome,
I have a question.
Sorry.
To both Nirmal sir and Dr. Kalpana madam. So say for example, you have a VIP patient. You have screened them 2 or 3 days prior to cataract surgery where the sugars are well under control. On the day of surgery, VIP patient came and you check the random sugar, it is around 250 or 240 or something like that. You have a compulsion of doing surgery, or you have to be very bold enough to cancel the surgery, or what is your take on it?
Usually we get physician's clearance for all the patients.
You have done it 2
Fitness
days
for
back,
all
ma'am.
patients.
You have done it 2
patient
days
is
back.
under treatment. I'll go ahead and proceed with the surgery. Explain to the patient. Post-operatively, the glycemic control has to be a little strict.
Okay.
I do not postpone the surgery.
Yeah,
I
I would
have a
ask
small-
Hari to respond because
Yeah.
he takes care of all that requirement for us. And also we have an in-house anesthetist before the procedure. So we take a call based on the risk assessment by the ophthalmologist and the risk assessment by the anesthetist. If both of us feel that it is not safe for the patient, we talk to the patient and then postpone.
So I think I will take it this way. So if it is a regular cataract surgery, no diabetic control, I think I will stick to diabetic control first and then wait for the sugars to come down and then get the surgery done on an elective day. If the sugars are not controlled, if it is a very, like a hypermature cataract that is there, in spite of having high sugars, I will say go ahead with surgery because vision is very important and it will be at a high risk concern. So this is what I would recommend. In the third situation where you have a good control and then on the day of surgery there's a fluctuation, I think, see, we are in days of just topical anesthesia where you have drops just given on the eye for local anesthesia, and if at all there are few people who are going to require a little bit of sedation. So most of the surgeries are either done in the morning or in the afternoon. So if someone is doing the surgeries towards the afternoon, I say have your morning breakfast, have your morning dose of sugars. If the person doesn't have a tendency to have a hypoglycemia, go have a small lunch at 11 o'clock, afternoon surgeries, go ahead, have the surgeries done. If it is morning surgeries, yes, if someone is coming NPO, don't have your tablets, have the surgery, then immediately half an hour post surgery, you are going to go and have your, you are allowed to have orals, right? So I think you can give your oral hypoglycemics or insulin, whatever he's on, have his food, and then go ahead with surgery. So I think my practice would be limited to this.
Thank you, sir. Thank you so much. On that same this thing, I'd like to speak to Dr. Hariharan with another question. Usually we retinal surgeons, when there's severe exudative maculopathy, diabetic macular edema with a lot of hard exudates in the macula. Hello? Can you hear
Yes,
me?
sir.
Yeah,
yes, sir.
okay.
Yes, sir.
So there's a lot of studies and scientific data to say that if you prescribe them statins for a period of 3 to 4 weeks, when we later on and then start treating the macular edema with laser and anti-VEGF injections, the results are much better. And a lot of studies advocate giving statins even in the presence of normal lipid levels. So is this, from a diabetologist point of view, is this a good practice? Ophthalmologists start this, and if so, what?
Sir, also fibrates for reducing the progression of diabetic retinopathy.
Yeah.
So I think, see, there are studies that say the progression of the retinopathy is better. If the procedure is done post having statins for some time, it gives better this thing. I will not stop ophthalmologists from prescribing statins. I will say please prescribe statins. See, although there are few side effects that are known with statins, and then there is I strongly believe that statins would be useful retinal surgery. If it's going to help the retinopathy, I think we should go ahead. And I don't think ophthalmologists should refrain from prescribing statins.
Thank you, sir. Thank you so much. We'll just have one last question for regarding diabetes and diabetic retinopathy because it's getting too long. How frequently does a physician or a diabetologist advise screening for retinopathy? When do you first advise, and then how do you implement it? Because that is a guideline is different, but implementation is different. This question is to both Dr. Hariharan and Dr. Vivek. How do you implement and how do you ensure this happens?
Okay, so I think at least for me it is very easy because I practice with Nirmal sir, and so we have a lot of common patients in this thing. But it's very difficult to convince someone to have an eye checkup, saying that okay, you have to check your eyes. So I say to my patients that the eyes should be checked every year, and if there's a specific requirement to check it more frequently, we should comply by it. But see, most patients think getting an optometrist to check the eye and having a glass on is an eye checkup, and it is very difficult to convince them towards going towards an ophthalmology checkup. I know I have a pretty standard practice, but I think for a regular, I mean, in my initial days as a physician practice, I had a lot of difficulty in getting this done. Now I have a regular system. So yearly once, get your eye checked, and then we'll go ahead. Because see, when we diagnose diabetes, we don't know, I mean, how long this person has been having diabetes. So I usually do it even in the first few months of my detection of diabetes.
Thank
Yeah,
you, sir.
to add to that point, only 10% of that OPD, diabetic OPD, have their eye examined in any center. Only 10%.
Definitely,
Whatever
sir.
counseling, or whatever
Whatever is done,
dietology,
yeah.
only
Even in
10%
all the
have their.
big centers, it is less than 5 to 10%.
Yeah.
Very difficult.
Single man centers, it will be around 10%.
I'll tell you my observation on this eye screening. Just a point. Whenever I have few physicians, diabetologists who regularly ensure that the patients get eye screened, and those patients actually hardly have any retinopathy. Probably because the diabetes is under control. And the people who are like not taking good care and don't have one proper diabetologist or something, they are the ones who invariably develop retinopathy. Vivek, your inputs, how do you ensure this is complied with?
Yeah.
What do you do
I
for
think
that?
The primary fault first actually lies with us. So we are not really pushy about screening for all. It's just usually a passing remark, and it's very difficult to convince patients who are absolutely asymptomatic regarding annual screening. Annual screening for type 2 and screening starts after 5 years for type 1. This is the formal recommendation as such. So we are not really being pushy about it. I think this is something, unless and until you have an ophthalmologist in house, it becomes a part of the standard protocol. The patient have to be referred. I don't think we are actually doing a good job, at least most of us, at least we have to accept that it's never been part of the normal protocol. The way we which aggressively screen for other microvascular, macrovascular complications, we actually leave the an eye gets a second.
And one more dilemma on the part of the patient is when they are asked to start on insulin for a short course, they get scared. They think that they'll get addicted to insulin for life, and they start arguing. It's very difficult to convince the patient to be on insulin. So how do you tackle that?
Yeah, there is no
everybody other than the panelists mute themselves, please.
Pokkadi madam, please mute your mic. Pokkadi madam, please mute your mic. I think a host can do it. Except the moderators and speakers, the host can mute everybody.
Yeah, thank you, sir. Nirmal sir.
Right. Sorry about that.
No problem, sir.
Please carry on.
Yeah, I think everybody is, the relevant people are unmuted. Yes, sir. So on that note of screening, I would like to bring in our rheumatologist here, because other than diabetic retinopathy screening, other thing we get, the ophthalmologists get references for is screening for ocular effects of systemic drugs and systemic diseases. So the most common being rheumatoid arthritis, SLE, and patients who need to be started on hydroxychloroquine. Patients on ATT, we see a lot of ATT-related optic neuropathy after the new regimen of ATT, where ethambutol is being continued for 6 months. It's almost becoming a pandemic, endemic now. So, sir, what would you generally recommend a patient on any systemic disease before he starts? Would you screen, and with specific reference to HQCS and ATT?
Good evening, sir. So my video is disabled, I think, after the change. But
You
it's okay.
carry on
I'm
talking,
Dr.
sir. We'll enable it.
So yes, I think the HCQ has been discussed for quite a number of years. The society has given very fixed guidelines. If you are giving 6 milligram, less than 6 milligram per kilogram per day, it's quite safe dose, and we generally use maximum 200 to 300 milligram per day. And it's predominantly used for patients with lupus, and less commonly being used for rheumatoid nowadays, because we do have other drugs. So, but if you look at the general prescription by physicians or orthopedicians, they tend to use hydroxychloroquine, but for a short period, and they switch over. So those who take hydroxychloroquine for a longer period, or we are planning for years together or months together, then yes, they need an annual screening. Of course, if they have eye problem, we recommend checking with an ophthalmologist first prior to starting. And HCQ-induced pigmentary changes are very, very rare. In the last 8-9 years, I've had only 2 patients so far. Thank you. The video is on now. So HCQ pigment retinopathy very rare. But yes, the legal point of view, we need to screen them every year for the initial 3 years. Once they are having no signs of retinal toxicity, then there is no concern. And after that, you can screen for every 5 years. But having said that, apart from lupus, we do not continue hydroxychloroquine for long for any of our rheumatology patients. That's the current guideline. And for arthritis and things, because we have other drugs, so we tend not to use hydroxychloroquine very often. Looking at the TB drugs, I do not follow them up because it's under the purview of chest physicians who normally monitor the ATTs. Other drugs like azathioprine and mycophenolate, methotrexate, they are quite safe from the eye point of view. And if we use steroids, that's the main concern. I think for different kinds of inflammatory disease, people tend to use steroids. So generally, the current recommendation is we need to reduce the use of steroids, perhaps not more than 6 months. I tend to prefer keeping them under 3 months. So we move on to definitive immune modulator therapy after 3 months. So, and if they have diabetes, if they have other vascular disease, then yes, definitely they can have a complication of the eye. But otherwise, short-term steroids, if they are well monitored, then less risk of having glaucoma or cataract. Thank you.
So just to summarize, you don't really screen all your patients who you put on HQCS, but once you started them and you're carrying on for more than a year, you ask them to have an annual eye exam, and that is up to 3 years.
Yes, and because the dose is less, 6 milligram per kilogram.
Yeah.
If you need longer than that,
chloroquine is more likely to cause problem than hydroxychloroquine.
Yes, indeed, correct. And we don't use nowadays chloroquine.
You don't use
So you
chloroquine.
can give also a simple test like home Amsler's test chart sheet for the patient. Ask them to laminate and use your near vision glasses and screen on their own once in a while.
Thank you,
Very,
ma'am.
very simple and effective test.
Yes.
There is
And
also some evidence that people who have a pre-existing macular pathology are more likely to develop HCQ toxicity, maculopathy. So, do you think it would be better to screen these patients once before starting HCQ to see if they already have some existing macular problem?
It
That
is
they would be
beneficial
at a
always.
higher risk.
Yes,
They may
it
or
is
may not
beneficial.
develop HCQ maculopathy, but they are at a higher risk as compared to the normal population.
Yeah, high risk population always, if they have diabetes along with the arthritis, then they will have a regular checkup anyway with ophthalmology. So we recommend them prior to the treatment.
Yeah, I'll just add a note on that, Dr. Jayashree. See, there are two aspects here. One is I am not too sure if any other pathology will predispose somebody to a hydroxychloroquine toxicity, because it is totally a different this thing. But
both these will affect the ISOS junction and the RP. So already if the RP is a sick RP, kind of like previous CSCR or something, they are there is some evidence.
Yeah, I'm coming to that. So what actually is the role of doing eye screening before you start hydroxychloroquine is you are trying to document that the macula was normal, or at least you're trying to document that the macula had some other pathology before you started. So because just a pigmentary changes in the macula can be because of anything. There are a lot of you can write an essay on it on what all can cause. So somebody should not blame you saying that your hydroxychloroquine caused this. So you can document saying that this person on CSR changes before you started him on hydroxychloroquine, and that has not changed after you started it. So that screening before you start is more for a legal standpoint, and screening before you start is not going to prevent, or it's not going to make you predict whether he will get it or not. I don't think it's going to do that. It is not a scientific standpoint. I think it's a more a legal standpoint.
Yes, sir.
So question to Dr. Vivek, sir. How do you handle antiplatelets and anticoagulants prior to cataract surgery or any vitreoretinal surgery?
Pertaining to cataract
any eye surgery?
Yeah. Pertaining to cataract surgery, right now there is no absolute indication to stop either aspirin or clopidogrel if even independently. If that is an absolute indication, which is only a patient with the prior stent, where you cannot afford to stop these anticoagulants, and even current guidelines says you can safely proceed with either aspirin or clopidogrel. Now, patients who are dual antiplatelets, now there is no definitive guideline. They say if you're planning an elective eye surgery, wait until the dual antiplatelet period is carried over, which is 1 year post stenting, and you can proceed with the cataract surgery as such. So right now, regarding antiplatelets, you don't have to stop prior to cataract surgery.
Does any dosage relevance is there, sir? People with 75 milligrams of ecosprin or and clopidogrel can continue, and those on 150 milligram can stop prior to surgery, something like that?
Right now, the higher dose of aspirin is no longer in vogue. It is only 75, which we extensively use, and especially in combination, it's only 75 plus 75. So there is no any specific recommendation regarding the dose. You can continue these simple antiplatelet agents prior to cataract surgery. Regarding anticoagulants as such, so regarding anticoagulants, this occurs only in one sitting where patient is not in sinus rhythm. He needs to be on anticoagulation, which is warfarin, and his INR is also on the higher side. And guidelines says for cataract surgery, you don't have to stop anticoagulants, especially warfarin, prior to surgery. If you're looking at other ophthalmic surgeries, in the patient who is an anticoagulation, where you anticipate an increased risk of bleed, so that is why you're stuck. In those patients, you stop warfarin for 3 days, and you bridge these patients with heparin, and stop heparin 6 hours prior to surgery, 12 hours prior to surgery. Go ahead with surgery, then restart heparin, then go back to warfarin. So we call this bridging therapy. So bridging therapy is for any surgery in patients who use on warfarin. They cannot afford to stop warfarin. The patient requires this anticoagulant effect. You bridge it with heparin, which is short-acting. Warfarin actually acts for 3 days. So you bridge it with heparin, stop heparin 12 hours prior to the procedure, go ahead with the surgery, restart them on heparin. So bridging is what we do for anticoagulants, but for cataract, you don't really have to. Cataract, you can proceed with warfarin, aspirin, or clopidogrel.
Yeah, I 100%
So what about
agree with you,
antiplatelets for other eye surgeries?
Yeah,
antiplatelets for other eye surgeries, for how long does it have to be stopped?
Yeah, there are clear recommendations, and as Dr. Vivek was saying, I'll just make things a little bit clear here. I don't think you can group all eye surgeries together. I think a topical clear corneal phaco is a
Yeah,
class apart from, say, a retinal surgery. Even in retinal surgeries, I think there's a lot of difference between you doing a 23 gauge vitrectomy for a macular hole and operating on a florid proliferative diabetic retinopathy. And the current recommendation, I have the study, I don't have it offhand, I have it in my system. There is no indication to stop any antiplatelet or any anticoagulant, even if warfarin, even if it's dabigatran, to stop for topical anesthesia cataract surgery. The problem in cataract surgery comes when you give a peribulbar anesthesia where you stick a needle into the orbit. You don't know where the needle goes. If you're unfortunate enough to get a retrobulbar hemorrhage, that time you might land up in trouble. That also has been circumvented by we doing subtenons these days because the bleeding is only from the surface. So you don't get a deep bleeder. It's a deep bleeder which is the problem. With regards to retinal surgery, again, antiplatelet, I don't ever want to stop them for any surgery except florid vascular pathology like PDR. And anticoagulants, because invariably I have to operate only under regional anesthesia, I would prefer them to stop and, as Dr. Vivek mentioned, go for low molecular weight heparin. Dr. Vivek?
Yeah.
One thing I wanted to add to Dr. Jayashrie's question is this duration, because a lot of times we see people stopping cloplet for 3 days and 4 days and 2 days and all, which I don't think makes sense. Can you please clarify on that?
Yeah, but it just boils down to the half-life of platelets, which is 5 to 7 days. You need to stop it before 5 days. Now, regarding you were clear about it. Your decision to continue or stop antiplatelets is purely based on the bleeding risk during surgery, and as a surgeon, you're the best one to decide on the risk of bleeding during surgery. Regarding cataract, it's clear. As you said, for topical, you don't have to stop anything. Regarding other ophthalmic surgeries, you decide stopping antiplatelets based on the intraoperative risk of bleeding. So in that case, you need to stop it for 5 days. So that is the current guideline. Now,
And when can it be restarted?
Restarted the next day after surgery. By you do not,
And would you do INR check on the day of surgery?
Yeah, if the patient is currently on warfarin, you're going to stop it 3 days even prior to you're planning surgery as such. So INR would invariably normalize on the day of surgery, and you're just going to bridge it with heparin, and heparin does not influence your INR.
No.
So you don't have to do a INR prior to surgery.
Can I ask?
You anticipate the prolonged effect of warfarin. If the patient's INR was very high prior to stopping, so you would want to make sure the INR is at least less than 1.5 before you decide on surgery. For heparin, you don't have to monitor anything.
So that's a key. Yeah, correct. Thank you.
Can I ask? Subramaniam sir.
Yes, sir.
Subramaniam sir, do you screen Hariharan sir? You can proceed with if it is relevant to the.
Just I wanted to know the ophthalmologist's point of view on stopping the antiplatelets. I think lots of ophthalmologists are not very comfortable operating on aspirin, clopidogrel, or anticoagulants. What is your take on this?
Kalpana madam.
Only if we block. Otherwise, most of the surgeries are topical. Even pterygium surgery, we start on brimonidine topical. So it blanches and gives quite a avascular feel. Only in extreme cases where the patient requires the peribulbar block. So I would hesitate to do with the anticoagulation on.
Okay, so
I have a different take on it.
There are certain ifs and buts we need to clarify. So topical cataract surgery, phaco surgery, clear corneal incision, no issue. On the other hand, if you're going to convert, there is a risk of converting from phaco to SICS, or you're going to add a peribulbar anesthesia. There's definitely a risk in these patients. So in that case, the surgeon has to do a risk assessment and then decide about stopping this. So a prior assessment will really help us to plan in this regard. Right, so you should not.
And there also
the
differentiation
statement that there's no need to stop for all cataract surgeries. So you have to qualify that statement with if it is a topical phaco and the surgeon is comfortable without conversion, or if at all there is a need for conversion without peribulbar anesthesia.
Yeah, just trying to make a distinction. When we say stop, I think we should clearly draw a line between antiplatelets and anticoagulants. So antiplatelets are hardly anything, whereas anticoagulants is totally different. So you shouldn't confuse these two categories. And as Dr. Vivek, just to summarize what we've discussed, the decision whether it needs to be stopped is actually the surgeon's. The decision to need to stop. I want this antiplatelet, like somebody may not be maybe comfortable with it. The surgeon is the one who is best aware of how much bleed he is going to anticipate. So the decision whether it needs to be stopped is the surgeon's. The decision whether it can be stopped is actually the physician or cardiologist or whoever it is. So there is a difference between need to be stopped and can be stopped. Let us say there is a situation where it needs to be stopped, but it cannot be stopped. Then you have to look at other options. I hope I made myself clear, or was I too confusing?
Yes, sir. Yes, sir. Thank you.
Okay.
Satya, next question, Satya.
We will move on to rheumatologist Dr. Subramanian, sir.
Yes.
So do you screen for dry eye regularly, or you realize it only when they present with dry eye complaints to an ophthalmologist, and do you screen for dry eye at your, or encourage them to screen for dry eye in case of patients with rheumatoid arthritis?
Yes. I mean, generally, dry eyes can be part of primary Sjogren, or it can be secondary Sjogren from rheumatoid. You don't see in other conditions from rheumatology point of view. Of course, any connective tissue disease overlap can also have dry eye syndrome. So in rheumatology, it's a multi-system disease. So our questionnaires with the patients always from head to foot, and we start from the scalp, hair until the foot. So the questionnaire will involve problems with the eyes, red eye, painful red eye, dry eye, tear secretion, and even in infections like conjunctivitis, all those things. And we have always the support of ophthalmologists, whether it's Arvind or Agarwal or Vasant, all of them are nearby. So I am very happy to involve them straight away. So, and being in IMA is one good thing, that they all have my numbers. So even the trainees have my numbers. So they ring me, and so the same way, the other side also, they get a problem, they send the patient referred right away. So so we screen regularly, and perhaps the primary Sjogren's they pick up first before it comes to me. And the secondary Sjogren's we pick up and get them along. So that's the way we do.
Okay, sir. Perfect. Perfect.
Satya, you can just go ahead with the immunomodulators with Dr.
Yeah.
Yeah. Okay, sir.
Yeah, you can. So, Sriram sir, நீங்களே கேட்டுங்க.
You carry on. You taken it over. Go ahead.
I have a question to Kalpana madam.
Yeah. Go ahead.
Do you require, or do you insist on having a standby anesthetist for every cases of cataract surgery or an eye surgery, or it is on problem based or systemic condition based?
Again, it depends upon the patient's condition. If they have too many comorbids and the fitness is not that great, I would definitely have an anesthetist standby and operate. If the comorbids are less, the cataract is less risky, I would go ahead and operate without standby.
Okay. So what is the proportion, madam? 90-10, 50-50, 60-40?
Not 50-50, maybe 80-20.
Okay.
80% I operate
without a standby anesthetist,
yeah.
And 20% of cases which require a standby, which has systemic risk factors, then you insist on having an
exactly
backup. Okay. Anna, Sriram sir.
Add that. So I always have a standby
Yes.
anesthetist for all surgeries. 100-0 is the percentage.
Yeah, I'll add my take on that.
You have a luxury then.
Of these,
not luxury, it is to self-care.
Yeah.
So self-care for myself and also patient safety for all my patients. Right? So I focus only on the eyes. They will focus on the patient as well as me and my blood pressure.
Yeah,
to the financial part. Sir, to the financial part.
No, I agree. I totally agree with what Dr. Nirmal said. Just to add to what Dr. Kalpana and Dr. Nirmal said, in my experience, any of these patients who are really high risk, who have CKD, who had a CABG, who have a low ejection fraction, who had multiple cardiac issues, None of them have ever had any problem intra, peri, or post-operatively because they are under the care of a good physician, bar cardiologist, bar nephrologist, and they are always well. Their heart rate is good. They are on beta blockers. Everything goes on fine. It is this patient who claims himself to be healthy, who will develop an accelerated hypertension and pulmonary edema. Just to digress, I had a patient who walked in for a simple intravitreal injection. The moment she entered theatre and lied down on the couch, we had not even painted her eye. She developed accelerated hypertension, pulmonary edema, and we had to resuscitate her and shift her to an ICU. So it is not about the one. Yes, I agree. There are certain patients who will require more assessment, preoperative assessment, and more care. But I think it also got to do with the kind of setup you work in. If you're the only doctor who can do basic, let's just say, put a line and do a CPR or give an IV drug, I don't think that is a good thing. I think there should be at least one more person who is capable of doing it within your premises. He not be inside your theater itself. He can even be outside theater, but he should be able to come in a couple of minutes if called. So as long as there is somebody who can take care of the BLS and basic ATLS within your premises, I don't think you need a standby. But in the absence of somebody being like that within your premises, I think you certainly need somebody like an anesthetist or somebody in the premises.
Okay.
This is also the NABH standards, even in eye care. So you said if there is a person and team behind you, you can certainly take the risk of operating, but you need to do a risk profile for your patient and then decide on the plan, both anesthesia plan as well as surgery plan.
Yeah.
So, Sriram sir, next question.
Yeah. Next question is Dr. Subramaniam about the immunomodulatory drugs. Sir, we are a lot, especially retinal surgeons like Jayashree, me, we also develop as uveitis specialists for some strange reason. So a lot of times we are faced with patients like VKH syndrome, sympathetic ophthalmia, etc., post-scleritis, where we need to start them on immunosuppressive and immunomodulatory agents. Of course, I draw a line. I go up to, let us say, methotrexate or azathioprine, beyond which I don't really venture. So do you think it is a good practice for the ophthalmologists themselves to assess and start and monitor a patient on immunomodulatory therapy? Or do you think we should necessarily involve a internal medicine specialist or a rheumatologist? And in case we are doing it on our own, what should we see before and how should we monitor them later?
Okay, sir. So yes, uveitis, if it is a part of the systemic disease, they need to be shared care. Like rheumatologist or bowel disease like colitis, Crohn's disease, or Angstpon, or even sarcoid, for instance, with respiratory physician. So, and the systemic immune modulator drugs usually will be looked after by them. Now, if it is idiopathic uveitis or panuveitis or choroiditis, managing by the ophthalmologist themselves, yes, you would normally start on oral steroids and then consider immune modulator drugs. And the normal screening we do is the blood count, liver function, renal function, and any history of interstitial lung disease before we start on immune modulator drugs. I think the first line would be methotrexate and azathioprine, and the second line could be mycophenolate and sometimes tacrolimus or cyclosporine. But the headache of monitoring regularly every 2 weeks and 4 weeks and every 12 weeks followed by that, that can be a problem. But if they are coming to you regularly, I think you may be the best person to monitor them, because if you don't have an in-house physician, then they need to have a two consultation separately, and it may not be available on the same day. All those practical issues are there. Having said that, if the patient is going to be on long-term immunomodulators, then perhaps the initial few months could be with a specialist, whether it's a physician or a GI specialist or a rheumatologist. And once they are stable, then you could continue to monitor them or look after them. And if there is a trouble only, you can involve the specialist. So that's about the monitoring. And if they have comorbidities, then always get the physician involved. So the bioavailability and the drug excretion may vary depending on the hepatic or renal disease. So it's better to involve them from the start itself.
So, as a
another thing I would like to know.
Yes, sir.
Yeah, sorry, Jayashree. Let me finish off with this. Sorry.
Another,
As an extension of this, sorry, Jayashree. As an extension of this question, same thing, a patient to be started on steroids most likely, and sometimes even immunosuppressive.
Yes.
A normal patient, what should an ophthalmologist see? A short course of say 4 to 6 weeks of oral steroid. A normal patient, what should the ophthalmologist screen and evaluate? That part of the question is to Dr. Vivek. And if he is a diabetic, should we send him to a diabetologist first, and then should we start the oral steroid? And that part of the question is to Dr. Harihar. Vivek first.
Yeah. If you actually go planning to start them on steroids, two things you're worried about. One is exacerbation of underlying hyperglycemia in a diabetic, and second, predisposition for an infection. Now, 20 milligram of prednisolone is the dose beyond which you expect a huge surge in blood glucose. Regarding type 1 diabetes, there is a risk of precipitating a deep diabetic ketoacidosis, so you make sure you refer them to his primary consultant as such. Titration of blood glucose is essential. You don't have to downgrade or de-escalate the dose of steroids purely for the need of optimizing his glucose control. We just intensify his glucose control with insulin, and you go ahead with this dose of steroids. Regarding 4 to 6 weeks, you don't expect any other metabolic complications with steroids apart from elevated blood glucose, short-term course as such. So in that aspect, I don't think you really need to worry about that. Regarding a non-diabetic, starting on the steroids prior to initiation, apart from screening for blood glucose, short-term course of steroids, I don't think there is anything else required from the ophthalmologist side in this perspective.
Shouldn't we do a tuberculosis screening and all before starting?
Not required. Not required. Prior to steroids initiation, not required. I think the second question was for Dr. Hariharan.
No problem. Okay. Sorry, I wasn't able to unmute myself after muting. I'm sorry. So I think we've dealt pretty much with most of the things which we wanted to. And this question is to Dr. Kalpana, madam. Madam, this is again regarding uveitis. What is your threshold to do a full battery of investigations for the patient with uveitis? What is your criteria? When do you say, okay, first visit itself, I will do all these tests, or you wait for a second attack or a repetitive recurrent uveitis? What is your criteria and your threshold to investigate thoroughly in a patient with uveitis for any systemic cause?
If it is a first visit and it is non-granulomatous, I would not go ahead with the full-fledged investigation. If it is recurrent, involving both eyes, and it is granulomatous, you see a lot of mutton fat KPs, I would definitely go ahead and do all the investigations. And also in the first visit, if there is pan-uveitis, there's involvement of posterior segment also, definitely I would go ahead and investigate.
Thank you, ma'am. I think we left out Dr. Hariharan sir's response for that steroid and diabetics. Sorry, sir.
Yeah, so I couldn't unmute myself, so I couldn't answer that.
I realized that.
Okay, so I think, see, steroid and diabetes, yeah, if there's a strict indication for a steroid, I think all ophthalmologists should start the indicated steroids as Dr. Vivek told, and I think you should not hold back the steroids just because someone has diabetes. But I will put them through an intensive monitoring. So we advise them about SMBG and then follow up. Then we have short follow-ups. We try to help them titrate their doses, and we keep them monitored. So I think that's the way to go ahead. And if someone is requiring a large dose of steroids, then I think put them inside the hospital, give them the steroids, monitor sugars, control it for them, and give it. This is how I will go ahead and do it. For short, lesser dose of steroids, I think OPD should be okay. We can do it as an OPD. If it is going to be 1 gram steroids or something like 500 per day, then it's a different story. I think we have to get them inside the hospital and get it done.
Yeah.
Other thing that needs to be monitored during the steroid is the blood pressure as well, because people have their blood pressure as well fluctuating during course of steroid. So I think that also needs a little bit of look into.
Yeah. So most uveitic conditions, the threshold of steroid of prednisolone is 1 mg per kilogram body weight. So I think most of them will need what you say.
Yeah.
Dr. Jayashree, you had a question when I had to interrupt you. I'm sorry. You can go ahead. After that, we'll move to the concluding remarks.
Okay, to Dr. Subramaniam, when we are managing a case together, a rheumatologist and an ophthalmologist, what is it that you want? You would want to know from the ophthalmologist side at every visit, because patients come to me and they say that the rheumatologist wants a letter from the ophthalmologist to decide about the dose. So, what would you exactly want to know from our side?
I think from the ophthalmology point of view, so generally when you start on steroids for uveitis, so we do not know the duration. And if it is recurrent uveitis, if you mention to us about at least the short-term duration, like 3 months or 6 months, or weaning over
for review cases, I meant.
Sorry, ma'am.
I meant for review when the patient is being treated for a rheumatological condition with an ophthalmological associated problem. So when he is being put on a drug by the rheumatologist, and every time he comes to visit the ophthalmologist, the rheumatologist wants the eye condition from us, stating that they would want to modify their drug dose.
Okay, so I think it differs by different rheumatologists. So generally, what we want to know is whether the eye condition has been in remission or not, whether any surgery planned when it is not completely recovered, and whether we can keep on a low dose of disease-modifying drug and consider stopping steroids. Only those 4 questions we are thinking in our mind when we are seeing the patient. So if the ophthalmologist mention that yes, it has gone into remission and we are happy in that way, then we would be keep them on disease-modifying drugs only rather than steroids along with it. So that is one. And number 2, in terms of reviews, so I think from our point of view, we normally review them every 3 months once they are stable and remission. If you also have a policy that yes, if they are very good, then they don't need to come every quite often and every 3 to 6 months, then it can be convenient for the patient to come for the single day appointment. So those 2 are the practical convenience. Other than that, if it is worsening, then we would like to know whether would need a biologic drug like adalimumab or infliximab, all those bio drugs, or even JAK inhibitors can be used nowadays. So that also we would like to know whether we need to change the approach to immune modulation. That's the other end of the spectrum. Thank you.
Thank you, sir. Thank you. Thank you so much. I think we've covered all the questions which we had planned to. I think we'll just move a minute to each of the speakers to give any concluding remarks if they have. I think we'll start with Kalpana, madam.
Okay, just one point I want to stress regarding screening for dry eyes in rheumatological patients. It's better we use surface staining, which picks up more cases than the shimmers or breakup. Rose Bengal or Lissamine green, whatever is available, you'll be surprised to see plenty of patients with a positive staining. Even if they are they'll be, most of them will be asymptomatic. So it's better we screen them with a surface staining to screen for dry eyes in these patients. I just wanted to add that point.
Thank you, ma'am. Thank you so much.
Dr. Vivek, sir.
Yeah, I just like to add one point regarding your need for statin therapy. Now, all diabetics have to be on statins irrespective of lipid levels. Okay, that is a current. Every diabetic invariably be on a statin. Now, health, yeah.
Opens another Pandora's box.
Opens another Pandora's box.
Yeah. So there's no question of whether you need to add it for the question of retinopathy. All diabetics have to be on statins irrespective of lipid levels. Now, the question is pertaining to retinopathy, is it going to be standard dose or intensive dose? So 20 milligram of Atarva is standard and 40 to 80 is intensive. Now, intensive dose actually has one benefit in the subset of prevention for the severe forms of retinopathy and need for intervention in patients with diabetic retinopathy. So that is where the intensive dose has a role. Fenofibrate has no role in clinical practice anymore. We don't even use it for any indications as such. So statins are the need of the hour.
Okay.
Thank you. Thank you. Thank you, Dr. Vivek.
Do you agree with that last
I'm
statement?
not going to get into the debate about statins now, so I like to conclude. See, I think ophthalmology and medicine working together is something that is, I mean, with so many ophthalmologists around, I think there should be few physicians at least who do work only for the ophthalmology kind of work. And I think this branch specialty should be something that should be focused on, because there's lots of areas where you have the ophthalmology and the physician interacting, and if someone can concentrate, like people who, now there are people who do pregnancy medicines. I think there should be people who do ophthalmology with the medicine part, and that will help both ends meet.
Ophthalmic
The
physician.
IMD. The IMD.
IMD or something like that. Yeah, should happen as a specialty itself.
Good.
Already we have microbiology, pathology, radiology are all.
Yeah, you have ocular microbiology.
This is the only exception. We should have it in future fast.
You even have ophthalmic anesthesiologists.
Yeah.
You could apply for DNB. You might get it.
Yeah. Subramaniam.
Subramaniam,
Yes,
sir,
it's
your
a
thoughts.
wonderful venture on the day of World Sight Day and Diabetes. And thanks to the Ophthalmic Association for involving me also as a dermatologist. I'm here in Tinnevelly and also in Madurai. I very much work with the ophthalmologist, and it's a really pleasure to be part of it. Thank you.
Jayashree, Dr. Jayashree.
Yes, sir. Back to diabetic retinopathy. So I would suggest, just a small suggestion, as all physicians and diabetologists follow the routine of giving all the investigations to be done on the next visit to the patient. When the patient leaves the clinic, I would suggest just mention that a letter from the ophthalmologist to be brought at the next visit. Regarding the status of diabetic retinopathy, which can be filed in their diabetic file itself.
I would second that. I know a few diabetologists who don't give the next prescription if they don't see that letter.
Yes.
Nirmal sir?
Yeah, so you are Dr. Satyan and Sriram Gopal, your concluding remarks. We can also get the remarks from our academic chairman, Dr. Jayaraman.
Jayaraman sir?
Thank you, sir. We had a wonderful, nice discussion to commemorate World Sight Day. Love your eyes. There are a lot of diabetes related questions and the statins. I enjoyed it. It's very, very useful topic for each and every members of our IMA and all the doctors. So ophthalmology is one of the expanding field. Lot of advancements from the pediatric to geriatric. Lot of advancements. I thank you, Nirmal Reddy sir, for this wonderful panel discussion and the first part, Dr. S. Ramakrishnan sir. So thank you very much. We are all enjoyed. So to Nirmal sir. Thank you. God bless.
Thank you.
Thank you, sir. I just like to make one point. With all this discussion, I think the single most thing which is key is communication. So as an ophthalmologist, when we send a patient to a physician, I think we need to communicate clearly. One thing which we did not touch upon as much as hypertension. Say an anti-ischemic optic neuropathy patient on antihypertensives. Every time I make it a point to write clearly that I don't want him on nighttime antihypertensives. So we have to communicate clearly the same way the physician to the ophthalmologist or a rheumatologist to an ophthalmologist. So communication is the key for better coordination and better productivity. Thank you.
Right, Satyan.
Sir, it was a wonderful session. To have views from physician, diabetologist, rheumatologist in one forum, because otherwise we need to call each and everybody individually and get their thought process. So it was a huge learning, and I think it will help in our ophthalmic community and also from the physician side or the general physician side to learn a lot about and integrating about, as Sariran said, physician and ophthalmologist working together very well. So It's thank you very much for having me as a moderator. Thank you, sir.
Thank you. So let me at the outset congratulate all of you for being part of this panel discussion, especially Dr. Sriram and Dr. Satyan for bringing up with nice questions and also making it a lively interactive session. I thank the panelists for giving us their time, experience and expertise and sharing all their views with us. So a few points from my side. So we can't work as ophthalmologists, we can't work in isolation. We need to work together with all the other specialists and other experts to give the standard of care to the patient. I think that is the key word, giving the optimal and standard of care. And also, it's not only framing the guidelines, we have to stick to the guidelines, like the diabetic retinopathy screening. I think both of us have to be really particular when we see the patient for the next time that they are screened for retinopathy from the physicians and diabetologists point of view, and from our point of view the sugar under proper control, because very often they keep on taking the same medicines for a year together without even checking. So we need to work together to give optimal care to our diabetic patient. And the third aspect is about the ROP screening. I think we should not be over scared about the medical legal implication as well and the compensation. So we are all ophthalmologists. We are trained into seeing fundus, irrespective of the age group, whether preterm or a small child. We have to see the fundus and then follow the referral guidelines. So optimal checkup, examination, and refer at the right time should be our mantra rather than avoiding these children. And of course, the anesthesia part of it and the controlling. So it's up to the risk profile for ourselves and for our patients. I personally feel having anesthetist really takes a major part of stress on my mind, but there is also economic burden and also the cost implications to this. So maybe we can work together with the anesthesia society to to bring some standard operating procedures on working together. So maybe a lot of things we could have discussed, but in this 1 hour, I think we covered a lot. Thanks to our panelists and the faculty, and also thank Dr. Ramakrishnan for giving a wonderful lecture on pediatric eye care. I'm sure it will be useful to all the ophthalmologists as well as the general IMA members, the general physicians, family practitioners, the other specialists involved in giving care to our patients. So thank you all so much. Dr. Jairam sir, your parting thoughts, and maybe I request Satyan to give vote of thanks, official vote of thanks later on.
Thanks all the stalwarts of ophthalmologist, Sriram sir, Jayashree ma'am, Kalpana ma'am, Hariharan sir, Vivek sir, Subramanian sir, and the president RK sir, and the yes, Ramakrishnan sir for the wonderful discussion on the World Sight Day. So thank you very much, Nirmal, for this wonderful arrangements along with IMA and TN Tamil Nadu Ophthalmic Association. Thank you, sir.
Satyan, over to you.
Okay, sir. I thank our IMA State President Dr. Palanisamy sir, President-elect Dr. Sennamil Pari, then our Honorary Secretary NRTR Tyagarajan, and our State Treasurer Dr. Alagus Venkatesan, and our academic ARC Chairman Dr. Jairam sir, who was very active in for this meeting and also for the upcoming Timakan meeting. And from our ophthalmic side, Dr. R. Ramakrishnan sir, our state president, and President-elect Dr. Nirmal Frederick sir, then Vice President Dr. Armal sir, and our secretary Dr. Sriram, and Treasurer Dr. Balaji, and also thank Dr. S. Ramakrishnan for giving us wonderful lecture about pediatric eye care for the physicians, and also thank our panelist Dr. Kalpana Suresh Madam, Dr. Hariharan, diabetologist and physician, Dr. Vivek Sundaram sir from Trichy, is a consultant physician, and Dr. Subramaniam, who is a rheumatologist at Tirunelveli, and our own Dr. Jayashree, ophthalmologist from Coimbatore. So it was a wonderful discussion. and thanks for doing wonderful short thought process sharing, and may this be a starting step in further integration of IMA and Tamil Nadu Ophthalmic Association, and percolating a lot of knowledge among ourselves. Thank you, Nanda, for being part of this special World Sight Day webinar. Thank you very much.
Thank you, sir. God bless you, sir.
And a special thanks to our IT wing, Dr. Vijay Kumar,
I missed that.
and the office people for helping us with this. Thank you.
Yes. Thank you, sir.
Thank you, sir. Have a nice day. God bless you. Nice.
Thank you.
Thank you.
Thank you, Vivek.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you, sir.
Thanks a lot.
Thank you, Nirmal sir.
Thank you. Thanks all
Thank
of
you, sir, Nirmal sir.
And
Time for lunch, Sunday lunch.
special thanks
Yes,
to
sir.
Niranjan.
We
Special
missed
thanks.
Niranjan.
Special thanks to Niranjan, unsung hero.
Yeah, Ranjan.
Is he online? I can't see his name anywhere. Maybe he's in some other.
He is here. I'll convey the. Okay. Thank you all.
Okay.
Thank you, sir. Thank you.
Okay.
Thank you, Sriram sir. Thank you.
Okay. Thank you, Satyan. Thank you so much.